Okay, great. Okay, so coronary artery disease. Coronary artery disease can be caused by smoking, hypertension, hypercholesteremia or hyperlipidemia, diabetes, and a sedentary life. There's stable angina, unstable angina, and MI. And basically, it's a fatty plaque in the coronary arteries that restrict blood flow to the heart. So just a couple of terms for you to take a look at here. So kind of an umbrella term is arteriosclerosis. And that is thickening and hardening of the arterial walls, but this is in the small arteries. So if there's thickening and hardening, then they can't dilate or be very flexible. Hold on one sec. And this happens as well just over time, just in our normal unhealthy habits and even with age. And then we have atherosclerosis. So this is different. This is underneath arteriosclerosis. And this is actually the buildup of plaque. And it's primarily in our intima area of our vessel. And it's a hardening of the arterial wall, but the large arteries. This causes major problems that we're going to get into in a moment, but basically it can cause obstruction. Plaque can break off, resulting in an MI or obstruction causing angina. These sections right here within the lumen, right here, these are normal products that we have in our lumens to help them work normally. So we have nitric oxide, which causes vasodilation, endothelium, which also causes vasodilation. We have prostacyclines, which inhibit clotting, and then this von Willebrand factor, which inhibits clotting. You might actually hear about this. I believe in peds, maybe it's actually a disorder. So we can vasodilate, we can vasoconstrict, and we can inhibit and activate clots just inside our lumen from our normal process. So when we think of hyperlipidemia, it leads to atherosclerosis, okay? So our cholesterol actually helps us. Comes from the liver, and it helps us with our making our cell membranes, hormones, and vitamin D. So it's not all a bad thing when we're thinking about cholesterol. It comes from your liver, as you said, as I said, as well as diet. So we have cholesterol and triglycerides. I've done triglycerides here as a TG just to make it a little less wordy. And our liver technically makes all the cholesterol that we need. So we technically don't need to ingest any cholesterol to do all of the things that it does in the liver. Now, our lipoproteins that we hear about, which is our VLDL, LDL, and HDL, they are actually carriers. So they actually help transport the cholesterol and the triglycerides through the bloodstream. Okay. Are very lethal. We call these lethal. So LDL is low density lipoproteins. And then we have very low density, and then we have high density. So the low densities are our lethal, so L for lethal. And then our HDLs is high for healthy. That's an easy way to remember that. Now our VLDLs have actually more triglycerides in them than the LDL has. And so because of that, the VLDLs is a transport. When it goes into the blood, it can transform into LDLs. Okay, so it takes the LDL and which has more cholesterol, and then it transports that cholesterol from the liver's liver to the cells, which is where we get our buildup of fat within our cells and our lumens of our arterial vessels. Now, our VLDL, so it transforms the LDL in the blood, but it also carries then the triglycerides throughout the body, and it deposits them in the adipose and the muscle tissues for ATP production, and that is fatty acids. So remember we spoke about fatty acids before, how we can break them down to cause sugar, to cause energy. That's where this comes from. Now, our liver also, once the cholesterol's in the liver, it also converts the cholesterol to bile salts, and that moves to the intestines, and then it's either excreted or it's returned to the liver. So let me take a look at this first, because you know I like to do this. So here's our liver. So we ingest our triglycerides and our cholesterol, and then the liver shoots out the cholesterol and the triglyceride with this VLDL. Some of it is transformed into LDL, which is our cholesterol, and then it gets deposited into our cells. Our HDL, our healthy lipoproteins, then remove the lethal from our cell to be converted back into, to be transferred into the liver. Okay, so it's this little cycle. If there's an excess, again, of cholesterol in our liver, it can then be converted to bile acid that goes into our intestinal tract. So some of this can be excreted out, our cholesterol, and then others that the leftover can actually go back into the liver. So we have medications that can help bind the fat and the cholesterol or convert it to help us excrete the excess cholesterol so that less of it goes back into the liver and then does this whole cycle again, giving us more lipids in our cells. Okay. So atherosclerosis. So that's how everything happens. But atherosclerosis, basically, it's caused from multiple things. Yes, it's caused um, from high cholesterol levels in your blood, because we always have LDLs running around in our blood, in our arteries. But there are things that cause damage, which we'll get to in a minute, to our intima layer that then allows the LDLs to go to come into our intima, and basically the macrophages transform these LDLs into something called foam cells. Foam cells are also called fatty streaks. This can actually, fatty streaks can be seen through diagnostics. Okay. What happens with these fatty streaks is then they start to clump together. And when they start to come together, we can have an inflammatory response within our intima, which cytokines and fibroblasts all come together to form this mass. Okay. As this occurs, though, it is also attracting these foam cells to that inflammatory process, causing the lumen to narrow due to all of the macrophages and the foam cells and the inflammatory response. Okay, so it starts to decrease the lumen, which then also decreases the blood flow. Did I go to the right one? Okay. So after time, when this the outside of the lumen is damaged, you're going to have, this is going to become hardened slightly in different sections. And so that causes more areas for the LDL to come into the intima. Okay. Now, with that fibrin, it causes like fibrotic changes in this wall. And so you might have some wall that's nice and elastic, and now all becomes fibrotic. And repeated offenses here really makes this hardened. Just like we've talked about all that inflammation, except here it's on the inside of our arterial vessel. So if this is really fibrotic and hard, obviously with, let's say, hypertension coming through here, it can cause this fibrotic and hardened area, outside area of the fibrotic tissue to crack and break open just like it did here. The problem here is though that there's so much buildup of foam cells and inflammatory response that this is displaced, and so it's like a bleeding. And so then what happens is our platelets come to form a blood clot. This blood clot, put a blood clot right here, for example, on this lower picture. This blood clot can actually become so large that it completely blocks the arterial blood flow. And then you have an MI because there's no blood going towards the heart to oxygenate the heart. Does that make sense? This clot can also go to break off, not cause a blockage, but break off and go into the heart and cause a blockage in the heart itself. Okay. So, and we're going to get to more on the heart in a second, but for hyperlipidemia, apart from diet and exercise, there are some medications that will help. So we have our statin medications, lovastatin. So here it reduces that cholesterol synthesis, increases the LDL receptors in the liver. So if it increases the LDL receptors in the liver, then it's not being pushed out, it's staying in the liver and it's not being pushed out into the circulatory system where it can go into the lumen and increase the foam cells. It can actually reverse plaque formation as well, because if we're taking statins, with exercise and diet regimens, if it's not much is going into the blood system, then we ourselves can start to decrease that plaque formation, but lovastatin helps that as well. Lovastatin is not that old of a drug. And so what we've learned from lovastatin is that it also has major anti-inflammatory processes. So that inflammatory process that is happening in the inside the intima here, the lovastatin will also decrease the inflammatory process. So if that's the case, then maybe this blockage here might not get as large, and maybe we'll have then increased blood flow to the heart. Bile acid sequestrants. So this is cholestyramine. You're going to see these a lot, very, very common. So what this does is it blocks the bile absorption in the GI tract. So if it blocks it, then it's not absorbed back into the liver. And so it helps us with excreting this cholesterol rather than it being put back into circulation. We have fibrates, gemfibrozil, very, very common. All of these are very common. otherwise known as lopid. And what this does is it reduces liver production of the VLDL in our liver. So what that does is it traps our triglycerides, because it's some cholesterol, but mostly triglycerides in our liver. So it also does not come into circulation. Nicotinic acid, you can actually buy this over the counter, niacin. And what this does is it blocks the hormone in the adipose tissue. And so it decreases all of our triglycerides, VLDLs and HDLs. It just decreases it. It's very mild, but it's a nice adjunct therapy when you're on these other medications, or maybe your hyperlipidemia is mild, so then you can take this. The only one of the big side effects with niacin is that it can cause flushing, but you can get an anti-flushing niacin that will help. Flushing is like blood flow to your face gets really hot and red, and you can get it all over your body. But it's called anti-flushing niacin, and that is really just kind of in the vitamin aisle in your stores. And then, of course, we have our omega-3 fatty acids, which also inhibit our VLDLs and triglycerides. And that is just an over-the-counter omega-3. But of course, the best way to get omega-3 with the most absorption is really through fatty fish, so like salmon. So just some terminology here. Hypertension is from either a narrowed lumen. So if our lumen is narrowed, it's going to increase turbulence right here, and so we're going to get hypertension. We can also get hypertension from an increased volume. So if we think of congestive heart failure or someone with renal failure, they might have hypertension because of the sheer volume that they have in their circulatory system. We have stable angina. So this is quite, look at this. So stable angina is chest pain with activity. So right now I'm sitting here, I'm not having any chest pain. If I went out and did a run and I had occlusion of 50% from these foam cells, from the cholesterol, I might get chest pain. And that's because I'm not getting the oxygen needed in the heart to withstand the amount of exertion that I am physically doing. And so stable angina, believe it or not, typically means you have about a 50% occlusion somewhere in your arteries, which is very large. Now, unstable angina and MI come under the heading of acute coronary disease. Hypertension does not, stable angina does not. These can be precursors, but they are not considered acute coronary disease. They are, however, under the umbrella of coronary artery disease. Okay? I'm not going to test you on that, but I need you to know that there is a difference. So unstable angina now is chest pain at rest. That is a 70% or greater occlusion of an artery. That can be in one place or in multiple places, but that occlusion is 70%. Trying to look here if this would be 70. This might be about 70%, or maybe that's like 65 maybe. But that is, so when patients have unstable angina, come to the hospital with chest pain and they're not exerting themselves really, that needs to be treated. And it is not it's not stable at all, because if you have unstable angina, it means that this small section right here can become blocked at any point just from the inflammatory process. And then an MI is actual blockage. So it's blockage causing lack of blood flow to the heart. And like I said, the blockage could be right here with the either the cholesterol literally joining together and causing a block. It could be where that plaque came off and then our platelet aggregation happened and our platelets blocked the blood flow, or the platelet aggregation itself, the clot could become loose, travel into the heart, and block the blood flow somewhere in the heart. Okay. So, and depending on where that blood clot ends is going to cause problems. So here we've got our left and our right artery. If a plaque was to block the arteries right here, this entire section would have no blood flow. That is can cause death depending on where it starts, because we maybe not be able to get interventions into them in time. If it happens up higher in the larger vessels, then that is a major MI and we might not get them back. So as you could see, it really depends on the size of the clot that or blockage that occurs in these arteries, and that will depend on how much damage is done and what the treatment is. So let's look at stable angina first. And a lot of these medications are similar. Okay, so our stable angina, we just talked about what that was. Now our treatment for stable angina is the following. It is aspirin, beta blockers, calcium channel blockers, nitroglycerin, and then our hyperlipidemia medications that we just went over. I'm actually going to unhighlight this beta blocker, and I'm just going to underline it because we've talked about beta blockers before. So aspirin, actually we've talked about aspirin before as well. But calcium channel blockers, and nitro, and the hyperlipidemias are the new medications that we'll be talking about. So for stable angina, aspirin, that's when you're going to give your aspirin, the baby aspirin, once a day. And check this out. So as you know, it's an antiplatelet, but it can reduce cardiac events by 1/3. 1/3 just by taking an aspirin a day. That to me is phenomenal. We have our beta blockers, so like atenolol, and basically what that is going to do is decrease the workload of the heart. I want you to remember that. We really want to know what's going to decrease the workload of the heart or increase the workload of the heart. So because our beta blockers decrease our heart rate and decrease our blood pressure, it decreases the workload of the heart, decreases the amount of oxygenation that we need, and then also decreases angina. These patients will probably have hypertension also. Calcium channel blockers, so cardizem. These are great because what they do is, as we know, calcium, if we have too much calcium, it causes tetany. So if we block calcium channels, which is this here, then we're almost going to get a relaxant effect. Now, I know this isn't true, but I'm going to tell you how I remember calcium channel blockers. I don't need to remember it anymore, but how I used to remember it was calcium channel blockers are Ativan for the heart, right? So Ativan is a benzodiazepine, and Ativan relaxes everything. So calcium channel blockers will decrease your heart rate, will decrease your blood pressure, and will decrease any kind of vasospasms that's going on from that inflammatory response and the irritation in the intima. And so it does a really good job. And then we have nitroglycerin. So this is a vasodilator. So we've got those vessels that are constricted because of the inflammation and because of the narrowing of the arteries. So a vasodilator is going to help open the lumen to get more blood flow through, which is then going to oxygenate the heart better. So then if we're oxygenating the heart, we're going to have less damage. Okay. Now, nitro, what it does is it also decreases the preload and afterload, so makes it easier for the heart to work. And then, of course, our hyperlipidemia medications that we just went over, because what's that going to do is it is going to help prevent this from either happening in the first place or prevent it from worsening. Okay, so these are all the meds that we use for stable angina. You're going to see a lot now in unstable angina, so it's the same. So with unstable angina, we're going to use our aspirin again. We can also use Plavix as a continuous therapy as well, because it is also an antiplatelet, and it would be considered, both of these could be considered prophylaxis for the ischemic events. We have our beta blockers again, and we have then now our calcium channel blockers, our nitro, with unstable angina, because we're really concerned about it either forming a clot or increased swelling. We might want to give them heparin now as an anticoagulant, so that it might help that blood clot from forming. Because that blood clot can literally just, as we've said, can block the entire blood flow to the heart. So we might want to give them heparin along with this aspirin and Plavix. This decreases infarct damage or death by 35% when used with aspirin. It's massive. So they come in with unstable angina, we get them on aspirin right away, we give them heparin right away. And then our hyperlipidemia medications. So as you can see here, we do everything that we can to decrease the workload of the heart. So we're decreasing the workload of the heart here. We're opening up the vessels here for more oxygen flow. We're helping prevent those platelets from forming if that platelet plug does get, or the platelet does, the plaque does open and form a platelet plug, as well as the heparin. And then the hyperlipidemia medications is to make sure that it doesn't get worse. So when we're talking about an MI, this first slide is really talking about MONA. So we have our blockage or our plaque ruptures, thrombus formation, vasoconstriction, decreases the blood flow. So ischemia is an insufficient oxygen supply. So ischemia would be the chest pain that you are getting from the narrowed lumen, not getting enough oxygen to the blood, to the heart. However, if that ischemia causes damage to the heart, so it continues and it causes damage, that is called infarction. So an infarction is that damaged heart right here that actually dies because we can't get blood flow to that section of the heart fast enough. So when someone does come in with an MI, the first things we do, and these are not necessarily in order, is MONA, which is morphine, oxygen, nitroglycerin, and aspirin. Those are our go-tos. And we say MONA because it's easy to remember, but it's not in order. And some of these are just given simultaneously. So the first three things that we want to do is, of course, give them oxygen, give them nitroglycerin, and these would be the first two. Then we would give them aspirin. Now the nitroglycerin, we give that in dosages. It is, let me verify this, but I believe it's 3 dosages, 5 minutes apart. So if you give someone a nitroglycerin for their chest pain and it vasodilates, and in 5 minutes, or 3 or 5 minutes, they still have chest pain, you give them another nitroglycerin immediately. If it's still does not help their chest pain, you give them another nitroglycerin.
Mhm.
Okay, there's a certain number that we'll give, and we'll get into that in a moment. There's a maximum of nitroglycerin that you can give. If the nitroglycerin doesn't work, then you go to morphine. Morphine, you say, is for pain. It is for pain, but it is also a vasodilator. So morphine is a vasodilator as well. So oxygen, aspirin, when we do our nitroglycerin, it's our first line vasodilator, so we give that as prescribed, which you'll see. And then if that does not work, then you go to morphine. Okay, this is only going to take a few minutes, and this is for stable chest pain. So chances are your patient right now is in the med-surg floor or cardiac floor. And so you can, this is a protocol. So whenever your patient is in the hospital for chest pain, this is a protocol that is at your dispense in the MAR. So the time that you would call the physician is after you've given the morphine, because the nitroglycerin does not work. You've given the morphine, and either their chest pain has subsided or it has not subsided, you call the physician at that point. Now, this is under the understanding that apart from chest pain, your patient is stable. If your patient is not stable, then you would call a rapid response.
Mm.
Okay, so this is a patient that is stable in the hospital, in the ER, or even in the med-surg tele floor. These are your normal protocols that you go to. Okay. Obviously, if it's a new onset of chest pain and the patient did not come in for cardiac issues, you would not have these at your dispense in the MAR, and so you would call a rapid response at that point, and you would have someone else call the physician while you stayed with the patient, because you need to get these orders right now on the MAR, and your doctor also being a new onset, which does happen, would also then need to order diagnostics to see what's going on. Okay? So apart from MONA, you'll see here that we have thrombolytics, anticoagulants, stool softeners, and sedatives. And I'm going to get into that right here. So our thrombolytics, our TPA, are clot busters. Remember we spoke about those? They really are mostly used for ischemic strokes. However, if that blood clot if the blood clot happens from the platelet aggregation, then this would be an emergency reason as to why we would need TPA, because just giving them a little bit of heparin or something like that is not going to solve the problem, because we need to get rid of that clot now because they're having a heart attack. They have no oxygen rich blood going to their heart. So that's when they might use thrombolytics for an MI. Anticoagulants we would also use. That is to decrease that risk of the thrombus. Stool softeners, actually, when someone is having unstable angina or is in the middle of having an MI and we're treating them, the last thing we want to do is have them straining if they're going to the bathroom, because that in itself can trigger arrhythmias. So we want no constipation for this patient. Even if it's right after the MI, or if they are having unstable angina, we don't want any arrhythmias to be triggered. Okay. Again, our antiplatelets, so just like that aspirin and Mona, we're going to add the Plavix. Our beta blocker, because we really want to decrease that workload of the heart, our hyperlipidemia, and then we can also give sedatives such as benzodiazepines. So benzodiazepines, if someone is having unstable angina and is afraid, or they're having an MI, it's not a full blockage, but they're having so much chest pain that it's causing maybe some ischemia and some necrosis in the heart, they are anxious, of course, right? So benzodiazepines, is going to help them be less anxious. By being less anxious, because anxiety will trigger that sympathetic nervous system, so the sedatives will help with that sympathetic nervous system so that they're not having as much of that sympathetic nervous system response, which would be an increased workload of the heart. So this is going to help them with their heart, but it's also going to help them with their anxiety. We do not need them to be anxiety ridden in this particular case because it's going to worsen their issue. And so it helps them feel a little bit better, and it also helps their heart. So it kind of does a double whammy there. So actually, I'm going to do this last slide before we get into hypertension. This is actually really good, a really good time to stop. So we have this really cool thing called collateral circulation. And as you can see, I just put a smile on my face because when I was in nursing school, I thought this was the coolest thing ever. And you might have heard of it before. So let's take, actually here, I want to get a picture of that damaged heart. I'm just going to copy this over and bring it here as well. Okay. So when we get blockage in the heart, we can get blockage anywhere. And we already went over this. So wherever the blockage is where we're going to have damage. So wherever this blood flow is going, this whole section will be damaged. So the higher up and the larger the arteries, the worse the damage. So here we have a large vessel that is damaged, and it's causing some ischemia to this section of the heart. But this is what happens. I need another picture to explain, or just to visualize here for you. So this is our heart. If we have this 50% blockage, let's call this, just for argument's sake, 50% blockage here, and our body senses that we have some lack of perfusion, lack of circulation. What it will do is, let's just take this little section down here. Okay, if you can see that at the bottom of my heart, of this heart. If we have some occlusion right here, but it's not fully occluded, it's just we have angina, stable angina, and then we have some unstable angina. What the body will do, because it hasn't occluded yet, right? Over time, the body, because this takes a long time, this is like a lifetime of buildup, our body will see the blockage right here, and it will start to form new vessels to go around the blockage. Now, this can happen for anybody, but it does typically happen predominantly for those people that exercise, so that get their heart rate up. So people can have, as you know, high cholesterol levels and still be healthy and run and do all the proper exercising. It's just a genetic factor, right? And also people can run and eat unhealthy and still get this plaque buildup. So this typically will happen for those people that exercise. It's not exclusive, but it typically will happen. So the body senses that there's less oxygen where it needs to be in the heart, and it actually makes these vessels to divert the oxygenated blood around the occlusion, around the narrowing, so that the blood will continue to oxygenate the heart. Even if this happens, even if you have then a full occlusion for this area, you now already have the collateral circulation. And so this full blockage does not affect how much blood flow is going to the different areas of the heart. That's pretty cool, right? I think so anyway. So it's 2:23, so I'm going to stop the recording right now.